You were told fasting cleans you, activating autophagy, burning fat, and restoring metabolic order. That story is mostly true, but one organ responds very differently inside your abdomen. While your liver rests and kidneys recalibrate, your gallbladder enters an unsettling kind of silence. This silence is not healing stillness. It is stagnation, disguised as rest and simplicity. The gallbladder is not a passive pouch meant to be forgotten during long fasting windows. It is a muscular reservoir designed to empty, refill, and stay chemically balanced daily. Inside, it sits bile, a volatile mixture with little patience for neglect or delay. Bile is built from cholesterol, bile salts, and phospholipids held in fragile equilibrium. As long as that equilibrium holds, bile stays fluid and flows without causing trouble. But equilibrium depends on motion, not your intentions, discipline, or health philosophy. When dietary fat reaches the intestine, cholecystokinin rises and commands gallbladder contraction. That squeeze flushes older bile out, making room for fresh, properly diluted bile. During fasting, dietary fat disappears, and cholecystokinin falls quiet like a sleeping switch. No signal arrives, no contraction happens, and bile simply waits and concentrates inside. Meanwhile, the liver keeps producing bile, because housekeeping never completely stops. With limited emptying, bile accumulates and becomes thicker as water is absorbed away. Cholesterol saturation rises quietly, without pain, without drama, and without early warnings. This is not detoxification. It is chemical crowding inside a very confined space. Autophagy may clean damaged proteins, yet it cannot squeeze bile out for you alone. In fasting, your gallbladder becomes a sealed room where crystals practice forming quietly inside. If you are over 40, this quiet chemistry can escalate faster than you expect. What forms first is not a stone, but a precursor that can still reverse. It is biliary sludge, microscopic crystals suspended in thickened bile like drifting silt. Sludge usually does not hurt yet, which is exactly why it stays unnoticed. The gallbladder feels calm, but internally, chemistry is sliding toward instability. Here is the counterintuitive truth. When unused, the gallbladder does not truly rest often. Stillness in this context allows toxicity to concentrate rather than disperse safely over time. Fasting can heal many systems, yet it creates blind spots when applied too aggressively. In the next minutes, we will enter this blind spot with precision and empathy. Because gallstones are rarely sudden accidents. They are slow decisions made silently over months, and the first decision is often simple: keeping bile trapped in prolonged quiet every day. Imagine a sharp pain under your right ribs, radiating backward, stealing breath and certainty suddenly. That pain has a name: biliary colic, and it often surprises people pursuing aggressive weight loss. Many begin fasting to feel lighter, cleaner, more controlled inside their own bodies again. Yet the speed of weight loss itself quietly becomes the gallbladder's most dangerous enemy. When fat tissue breaks down rapidly, cholesterol stored inside adipocytes floods the bloodstream. The liver captures that cholesterol efficiently, then redirects it straight into bile production. This process is called cholesterol mobilization, and it accelerates dramatically during rapid lipolysis phases. Under normal eating conditions, bile salts keep cholesterol dissolved and chemically cooperative inside bile. But fasting disrupts this balance through two simultaneous and compounding biological mechanisms. First, gallbladder contraction weakens because dietary fat no longer stimulates cholecystokinin release. Second, bile salt recycling from the intestine slows as enterohepatic circulation becomes underused. NIH. Metabolic studies confirm bile salt pools shrink during prolonged low intake states. With fewer bile salts available, cholesterol loses its chemical escorts inside gallbladder bile. Supersaturation begins quietly, like sugar crystals forming at the bottom of cooling syrup. This is where biliary sludge thickens, and gaining mass, texture, and future momentum silently. The gallbladder is now immobile, overfilled, and chemically imbalanced all at once. This combination creates what clinicians call a perfect storm for gallstone formation. Importantly, fasting alone is not the villain in this story. The danger emerges from pairing gallbladder immobility with a cholesterol flood simultaneously. You are emptying fat stores aggressively while preventing bile from clearing itself naturally. That contradiction traps cholesterol inside a motionless reservoir with diminishing solubility support. Many people miss this phase because sludge rarely causes immediate, dramatic symptoms. Discomfort appears later, often during refeeding, when the gallbladder finally attempts contraction again. That contraction can push sludge into ducts, triggering spasms, pain, and inflammation suddenly. At that point, surgery often enters the conversation far sooner than expected. Gallbladder removal is common, but it permanently alters fat digestion and bowel regularity. Chronic diarrhea, bloating, and nutrient malabsorption frequently follow post-surgical adaptation periods. This outcome feels shocking because fasting was chosen as a health intervention initially. Here is the uncomfortable insight. Rapid improvement strategies often ignore slower organs entirely. The gallbladder adapts slowly and punishes impatience more than almost any digestive structure. Weight loss speed matters less than bile flow consistency during metabolic transitions. Without flow, chemistry stagnates, and stagnation always invites crystallization eventually. In the next section, we will examine the recycling loop that usually prevents this disaster. Because when that loop breaks, symptoms appear even without stones forming yet. You might wonder why some people fast comfortably while you feel bloated, nauseous, or unwell afterward. The answer is not willpower. It is a stalled recycling system working silently against you. That system is called enterohepatic circulation, a loop connecting liver, gallbladder, intestine, and back. Under normal conditions, bile is released, used, reabsorbed, and recycled with remarkable efficiency. About 95% of bile salts are reclaimed in the ileum after digestion. This recycling conserves resources and keeps bile chemically balanced for future meals. Fasting disrupts this loop by removing the very trigger that keeps it running. Without meals, bile release decreases, and intestinal reabsorption slows dramatically. NIH, digestive research shows prolonged fasting reduces bile salt pool size measurably. With fewer bile salts returning, the liver produces bile that is less chemically stable. Cholesterol becomes harder to keep dissolved without adequate bile salt support. This instability does not cause pain immediately, which is why it often goes unnoticed. Another overlooked factor is phosphatidylcholine, a phospholipid crucial for bile fluidity. Phosphatidylcholine helps wrap cholesterol safely, preventing it from clumping together. This compound depends heavily on dietary choline intake from eggs, meat, and fish. During aggressive fasting or low-fat dieting, choline intake often drops unintentionally. As phosphatidylcholine availability falls, your bile loses another stabilizing force quietly. Now bile is thicker, salt-poor, and cholesterol-rich inside an unmoving gallbladder. This is how biliary sludge graduates toward calcification and eventual stone formation. Sludge itself is not yet stone, and that distinction matters profoundly here. The good news is sludge can dissolve if flow and chemistry are restored timely. The bad news is neglect allows calcium salts to deposit and harden permanently. Once calcification occurs, reversal becomes unlikely without surgical intervention later. Here lies a critical insight rarely explained in fasting conversations clearly enough. Low-fat diets combined with fasting create a double insult to gallbladder physiology. They remove contraction signals while starving bile of its chemical stabilizers simultaneously. This is why some people feel worse the longer they eat clean and avoid fats. Their gallbladder is starving for movement and molecular support at the same time. Symptoms like nausea, fullness, and discomfort during refeeding are early warnings. These are not detox signs, they are mechanical and chemical distress signals. Ignoring them does not build resilience. It accelerates structural failure quietly. Understanding this loop reframes symptoms as messages, not personal shortcomings or intolerance. In the next part, we confront the paradox that fasting still remains necessary. Because despite these risks, fasting can also rescue gallbladder function long-term. That contradiction is where intelligent strategy replaces fear or blind enthusiasm. Pause here, because the story is about to turn against what everything so far implied. If fasting creates gallbladder risk, why do physicians still prescribe it for metabolic disease? This contradiction confuses many people and leads to extreme positions on both sides. The deeper truth is that gallstones are rarely caused by fasting alone. The primary driver behind gallbladder dysfunction is chronic insulin resistance, not temporary food absence. Elevated insulin alters bile composition and reduces gallbladder contractility over time. NIH endocrinology research links hyperinsulinemia to impaired gallbladder emptying directly. Insulin resistance also increases hepatic cholesterol secretion into bile continuously. This means many gallbladders are already compromised before fasting ever begins. In that context, fasting is not the original insult, it is the stress test. Fasting lowers insulin levels and gradually restores metabolic sensitivity across tissues. Over time, improved insulin sensitivity improves gallbladder motility and bile chemistry balance. This is why fasting helps fatty liver disease and reduces long-term gallstone risk. But the transition period is where danger concentrates, not the destination itself. As insulin drops, fat mobilization accelerates, flooding bile with cholesterol temporarily. Simultaneously, gallbladder contractions may still be weak from years of resistance. This overlap creates a metabolic danger zone that is easy to overlook. Doctors see this pattern after bariatric surgery and extreme caloric restriction frequently. Rapid metabolic improvement paradoxically increases gallstone risk during early phases. This does not mean fasting is wrong. It means timing and preparation matter profoundly. A gallbladder adapted to insulin resistance cannot instantly handle metabolic freedom gracefully. Forcing long fasts onto such a system is like sprinting on an atrophied tendon. Some individuals tolerate this transition smoothly because their bile flow never fully stalled. Others carry silent sludge already, waiting for one more imbalance to solidify. This explains why fasting helps some people immediately while harming others unexpectedly. The method is not dangerous by default. The context determines the outcome. Fasting without gallbladder support is reckless only when adaptation capacity is exceeded. The goal is not avoidance, but intelligent sequencing and controlled metabolic descent. If fatty liver is severe, abrupt 48-hour fasts increase unnecessary risk. Gradual fasting windows allow gallbladder motility and bile chemistry to adapt together. This is where nuance replaces ideology and physiology replaces slogans. Healing requires stress, but only stress the system is prepared to metabolize safely. In the next section, we shift from warning to strategy with practical safeguards, because gallbladder protection does not require abandoning fasting altogether. It requires understanding how to stimulate bile flow without breaking metabolic benefits. That balance is subtle, achievable, and far less extreme than most advice suggests. The goal now shifts from fear to repair, from avoidance to intelligent biological cooperation. You want autophagy benefits without turning your gallbladder into a stagnant chemical reservoir. The first safeguard is hydration, because bile is mostly water before chemistry complicates it. Dehydration concentrates bile rapidly, accelerating cholesterol crystallization inside confined gallbladder space. Electrolytes matter too, because sodium and potassium influence smooth muscle contractility subtly. A dehydrated gallbladder is not resting. It is thickening its contents under silent pressure. The second safeguard surprises many people. Black coffee during fasting can be protective. Coffee mildly stimulates cholecystokinin release, encouraging gentle gallbladder contractions without significant caloric intake. Clinical observations show coffee drinkers have lower gallstone incidence than abstainers consistently. This does not mean coffee is mandatory, but it can act as mechanical insurance. The third option involves bile acids, specifically water-soluble forms used under medical guidance. Taro or sodium oxycholic acid, known as TUDCA, helps thin bile and improve flow characteristics. It does not dissolve stones, but it reduces sludge formation during rapid fat loss phases. Physicians use similar bile salts after bariatric surgery to reduce gallstone risk. This is not supplementation advice. It is physiological context worth discussing with clinicians. Another strategy is controversial but effective for high-risk individuals transitioning into fasting. It is sometimes called dirty fasting, though the name oversimplifies its biological intention. A very small amount of fat can trigger gallbladder contraction without spiking insulin significantly. Medium-chain triglyceride oil is commonly used because it is rapidly oxidized by the liver. This is not cheating. It is mechanical activation for an organ that requires movement. Think of it as physical therapy for the gallbladder, not nutritional indulgence. For people with prior sludge, stones, or strong risk factors, this matters profoundly. Ignoring gallbladder mechanics while chasing metabolic purity is how complications emerge unexpectedly. The principle here is stimulation without overload, motion without disruption, signal without shock. Fasting should reduce insulin, not paralyze digestive organs indefinitely during adaptation. Shorter fasting windows, like 14 or 16 hours, allow safer transitions initially. As bile flow improves, longer fasts may become tolerable without chemical stagnation risks. No strategy is universal, but gallbladder physiology follows consistent mechanical rules. Movement protects chemistry, and chemistry protects structure over long metabolic timelines. In the final section, we will identify who must be especially cautious immediately, because risk is not evenly distributed, and ignoring that reality causes preventable harm. At this point, one final responsibility remains: identifying who must approach fasting with extreme caution. Medicine has long recognized a simple but powerful gallstone risk framework called the 4F rule. Female sex increases risk because estrogen raises cholesterol secretion into bile significantly. 40 and beyond matters because gallbladder motility naturally declines with age. Fertile status, including pregnancy, shifts hormones that slow bile flow and increase saturation. Fat mass contributes by increasing baseline cholesterol turnover during weight loss transitions. If you recognize yourself in multiple categories, long fasting is not a starting point. For high-risk individuals, jumping directly into 16 or 20-hour fasts is reckless. A 12-hour eating window allows metabolic benefit while preserving gallbladder movement safely. Gradual adaptation protects organs that cannot instantly remodel after years of metabolic stress. Gallstones are not a moral failure. They are a mechanical and chemical mismatch over time. Your body is not fragile, but it is specific about the conditions it tolerates well. The gallbladder evolved for intermittent feeding, not prolonged silence without stimulation entirely. When stress exceeds adaptation speed, even beneficial interventions become damaging unexpectedly. This is why fasting success stories vary wildly between individuals with similar discipline. Biology responds to history, hormones, and structure, not motivation or online protocols. Here is the hopeful truth often missed in fear-based medical messaging. Biliary sludge is frequently reversible when addressed early and intelligently. Flow restores chemistry. Chemistry restores structure, and structure restores tolerance gradually. The body repairs itself continuously, but only when signals arrive in the correct order. You do not need to abandon fasting to protect your gallbladder long term. You need to sequence stress, allow movement, and respect individual risk profiles honestly. Think of fasting as removal therapy, not punishment or proof of strength. Removal heals systems, but understanding prevents collateral damage during the process. Never force an organ to sprint when it has forgotten how to walk first. Listen to right-sided discomfort, nausea, fullness, or pain during refeeding carefully. Those are messages, not obstacles, and ignoring them never produces resilience. True optimization is not extremism, it is cooperation with biological constraints. Use moderation as protection, but use comprehension as your primary safeguard. Because health is not earned through suffering, but preserved through informed restraint. Before you leave a 1 if you want more health topics rarely discussed openly. If you want to catch the next videos, leave a 1 so I know you're waiting.